general presentation on that. I will come to the specific case scenario a little later. So the questions that you may have to remember for exam purposes: definition and types of diabetes. What is diabetes mellitus? What is the condition and what are all the types that you know? What are the pathophysiology biochemical changes due to glucotoxicity? What exactly is glucotoxicity? What happens when your blood glucose levels go up? And the clinical features and what are all the systems involved: cardiovascular, autonomic, airway, renal, respiratory, immunology, nervous system, gastric, all these things, systems which are involved, and what investigations are needed with regard to cardiovascular, neurosurgery, nervous system, renal, airway, control of glycemia, treatment, pharmacology of OHs and insulin, what are the complications, the cardiovascular system complication, nephropathy, neuropathy, diabetic autonomic neuropathy, metabolic DKA, and nowadays we have one extra condition apart from DKA and HHS is euglycemic DKA with a newer drug which is now more popularly prescribed by both cardiologists as well as the diabetologists. I will come to that later. And treatment of complications like DKA, anesthetic management, pre, intra, and post-op, including monitoring of blood glucose and insulin therapy guidelines. So these are the various headings under which you should read and remember this topic. Now, diabetes mellitus is a combination of Latin and Greek words. The word diabetes means siphon or pass. Mellitus means honey-like. So passing sweet urine is the literal meaning of the word diabetes mellitus. So it's a group of metabolic disorders due to complete absence or deficient or resistance of insulin in the body. Classified into 4 types. Type 1, which is the total lack of insulin because of the destruction of the Langerhans cells or the islets of Langerhans cells due to it is an autoimmune condition, or it can be precipitated following a viral infection also. And then type 2 is it is a decreased production and resistance, and type 3 is gestational diabetes occurring in pregnancy, and type 4 is classified as other things like due to excessive external administration of steroids or Cushing's disorder and other endocrine systems. The major complications are classified into microvascular and macrovascular. Microvascular happens in the eye, that is retina, and kidney and the nervous system. The macrovascular complications happen in the brain in the form of stroke or CVA, and the TIA or cognitive impairment, and in the heart it can be a coronary artery disease, and in the extremity it can be peripheral vascular disease. Now, how is glucose balance in the body? So if you see the homeostasis of a stable internal environment is mainly by glucose homeostasis. Insulin is the most important regulator of this metabolic equilibrium. But along with that, you require some neural input, metabolic signals, and other hormones, counter hormones like glucagon to maintain a stable level of glucose. So this is how the glucose gets absorbed from the intestine and goes directly to RBCs can take up glucose without insulin. Brain can take up glucose without insulin, whereas muscles and other organs they require insulin for uptake of glucose, and excess glucose is normally stored in liver as glycogen, and then it is converted into triglyceride and adipose tissue. So excess of glucose intake results in putting on weight because that glycogen will be converted to adipose tissue also, and breakdown produces some ketone bodies when there is a reduced level, and lactate and alanine also contribute to what is called neoglucogenesis from other substrates. So there are so many mechanisms which result in the glucose balance in the body, and abnormal insulin molecules or counter-regulatory hormones or anti-insulin receptor antibodies, cytokines are all the reasons for insulin resistance. So you can see this is the the triangular purple thing is the insulin. So it has to come and occupy the receptor site here. Insulin receptors are there on the cell surface, and once they occupy that, there is an internal signaling mechanism by which this blood-4 transporters are open. So you can see these hexagonal bluish things are the glucose, they enter that inside the cell. So this is the normal mechanism of glucose uptake in the fat and muscle cells. When there is a defect in the signaling, this channel does not open. Or if the insulin is not able to bind to the receptor because of its structural abnormality or antibodies, then also this channel will not open, and so uptake will be reduced. Then the blood level of glucose will go up. And this hyperglycemia, what are all the ill effects of that? Then normally it goes up to the stage of pyruvate inside the cytoplasm, glycolysis, and then it enters the mitochondria for oxidative phosphorylation, and excess of that starts producing the main pathology is oxidative stress. This oxidative stress affects the endothelium and causes endothelial dysfunction, which results in inflammation, leukocyte adhesion, vascular remodeling, LDL oxidation, platelet aggregation, and gradually produces atherogenesis and arterial stiffness. So this happens in both the large vessel and small vessels. So it is mainly a micro and macrovascular defect that sets in. In the type 2, what happens? There is an increased glucose production, impaired insulin secretion, inefficient utilization, and in addition to that, if the patient starts eating glucose without restriction, that also contributes to hyperglycemia. So the insulin insensitive organs in our body are brain, GIT, RBC, and to this you can add cornea and the skin. And another exam question they may ask you is, what is the relationship between the capillary blood glucose, plasma glucose, and the whole venous sample blood glucose? Any idea? Normally, capillary blood glucose is 7% more than plasma glucose. So what about the relationship between plasma glucose and whole blood or venous sample glucose?
15%.
Less than plasma glucose.
Yes,
Okay?
sir.
So whole venous blood glucose is 15% less than plasma glucose. Why? What is there in the whole venous blood? What is there in plasma? Why there is a difference between the measurement in plasma glucose to whole venous blood glucose?
RBCs.
RBCs.
RBCs have less water, okay, whereas plasma has 93% water and 7% of proteins. Whereas here it is 23% of 23% only water is there in the RBCs. So the dilution becomes less, so you get value is less. And this is the histology of the islet of Langerhans. So you have that delta cells, RBCs, everything. So the beta cells are the glucose sensors. So whenever the blood glucose level is more, glucose enters the beta cells through another transporter called blood-2. So what we saw in the muscle and fat cell is blood-4 transporter, whereas for the insulin beta cell secretion you require blood-2, through which the glucose will enter, and once it enters, it will be converted into glucose 6-phosphate, just like the first step in the glycolysis in the cytoplasm, and that will stimulate the potassium channel to block the potassium entry, and that will open up the calcium channel, and this hyperpolarization causes the release of insulin. So that is the simple mechanism how insulin is released from the beta cells. Now steps in the synthesis of insulin are The first is the pre-pro insulin, where it got a beta chain and an alpha chain, which is connected by the C chain or the C peptide, and there is a terminal sequence. Then from pre-pro it becomes pro insulin, where this terminal signal sequence is removed. You have the beta chain connected with the alpha chain by the C chain, and then this C chain is also cleaved. That is what is called the C peptide. That once that is cleaved, now you have the alpha and beta chains, or A and B chains only, which are bound by the disulfide bridges here. So there are two disulfide bridges connecting the chain A and chain B, and the third disulfide bridge is within the chain A itself. Okay. So chain B is a longer chain and chain A is a smaller chain with the 21 and 30 amino acids. And by changing the sequence, we are able to synthesize the newer insulins that we are using today. So chain B is 30 amino acids and chain C is 20 amino acids, and each one has got a fixed arrangement of these amino acids which are there, like B, and this is how the signaling system that takes place. As I showed in the earlier picture, insulin receptor, insulin has to come and occupy, and then immediately cellular signaling system activated, and that results in glucose transport inside the cell, and then the whole thing starts assimilating the glucose. Now coming to the pattern of insulin result, it's a biphasic pattern of release. So pulsatile release, short-term blood glucose control after a meal, and protracted release, long-term insulin release from cell growth, cell division, and protein synthesis, which are taking place continuously. So this is the mechanism of insulin action, again shown by this how alpha and beta subunits work, and this is the basal bolus insulin concept of insulin secretion. So this red line shows the basal secretion, and this yellow line shows the spurt or increase in the bolus. So this is breakfast, lunch, dinner, and HS before the time you have another requirement for the entire night. So this again, the picture shows another simple way of the insulin coming and occupying the receptor. Before it occupies, the channel is closed. The glut receptor is the transporter is closed. So once it occupies that, this glucose transporter channel opens and glucose is able to enter the cell. And in patients who have the resistance, this insulin is not able to bind to the receptor on the cell surface. So it is not able to open this blood transporter, and can see the blood sugar level is normal, whereas in patients with resistance, because glucose is not able to enter the cell to get the blood sugar level going up. Now there are four methods of glucose toxicity. The first one is called the polyol pathway. Whenever you have excess glucose which cannot be utilized in the normal way of cytosolic glycolysis, combined with the oxidative phosphorylation at the mitochondrial level, and even when oxygen is available, this excess, what happens, it is first converted into sorbitol and then goes into converted to fructose. So this is what is called the polyol pathway, where glucose is converted into another form of glucose, what is called the fructose. And this will also go into what is called the formation of advanced glycation end products. So glucose will undergo what is called shift base, then amide product, and end up with a combination of glucose combined with amino acid. That is, protein and glucose will combine and produce these advanced glycation end products, which are toxic to the health. And this auto-oxidation, lipid peroxidation, all these things end up in producing various toxic metabolites, which are, that is what is called the glucotoxicity. And these things take over a period of time, from hours to days, days to weeks, and then weeks to months. Slowly they produce all that. That is why the more the chronic nature of the diabetes, more these changes will have time to activate, and that is why you get the target organ dysfunction. Now there are four mechanisms which you have to remember for this glucotoxicity. One is the protein kinase activation. The other is superoxide production, which is otherwise also known as oxidative stress. Then hexosamine production, which is the another byproduct which is happening, and so hyperglycemia induced mitochondrial superoxide production happens in the polyol pathway, hexosamine pathway, protein kinase C pathway, and advanced glycation end products pathway. So you can see all the four described here. Glucose getting converted to fructose, it's called the polyol pathway. Fructose getting converted to glucosamine and UDA-GN, it is called the hexosamine pathway. Then diacylglycerol pathway or PKC pathway, and otherwise finally it goes into what is called AGE pathway. So these four pathways result in production of this what is called the superoxide, which is the resultant oxidative stress that attacks the endothelium of the blood vessels and causes all the vascular changes. Now coming to diabetic ketoacidosis, it's a serious complication of diabetes, more common in type 1 patients, but it can happen in type 2 also, mostly caused by infection or missing insulin dose or adding steroids or stress, and present us with vomiting, abdominal pain, excessive diuresis initially, and then later on dehydration, fruity odor in breath, gasping type of breathing, altered sensorium, weakness, all these things will be the clinical symptoms. And diagnosed by severe hyperglycemia, ketones in blood and urine. Normal value is between 0.1 to 1 millimole per liter, and the ABG showing anion gap acidosis. Treatment is by bound correction of dehydration with saline during first hour with insulin to reduce blood sugar. Correction of hypokalemia with from second hour. That is usually once you start the insulin, glucose will start entering the cells. Along with that, it will drive back the potassium also. Potassium comes out to correct for the acidosis. So once the patient starts correcting the acidosis, potassium will go back into the cells and hypokalemia will result. So we have to go for treatment. The differential diagnosis for DKA is hyperglycemic hyperosmolar syndrome, with where the blood plasma glucose will be very high in this HSS, whereas the DKA it may go maximum to 14 millimoles, whereas here it may go up to 33. And pH will be mostly normal in hyperosmolar syndrome, whereas it will be mild, it will be slightly decreased, moderate it will be 7 to 7.24, and with severe DKA pH may go down to less than 7 also. And bicarb will be definitely gradually reduced depending upon the severity, whereas it is normal or more than 15 in hyperosmolar syndrome. And ketones are very negligible hyperosmolar syndrome. So there is no ketone mass, no ketone production, and osmolality will be very high in hyperosmolar syndrome because of the hyperglycemia, whereas here it is variable, and the anion gap is very high, and mental status patient usually presents with stupor and coma and hyperosmolar syndrome. So this is the triad with which patients come. Both have the same triad. Hyperglycemia is present in DKA, but it is very severe in hyperosmolar. There is metabolic acidosis, but there is no metabolic acidosis, but only an elevated serum osmolality, and both have dehydration. Volume depletion will be there because of the osmotic diuresis produced by the sugar. and ketonemia will be present in DKA, which is not there. And these are the pathogenic changes that happen because between the two things. So there will be hyperlipidemia also present in DKA, whereas mainly it is hyperosmolarity which is present in HSS. And the 5 I's for DKA: insulin deficiency, infection, inflammation, intoxication, or it can be iatrogenic due to steroid, thiazide, symptomimetics, and antipsychotics. And sometimes, rarely, with an acute myocardial infarction or CVA also, you may get a DKA. Now, coming to the euglycemic diabetic ketoacidosis, which is now very, very common because of the usage of SGLT2 drugs, which are usually now introduced into the market for control of patients with severe hyperglycemia and diabetes. So, original description were all patients were severely hyperglycemic, whereas patients nowadays get the features of DKA, that is, ketones become positive, acidosis is present, but the blood sugar is sometimes less than 200 also. And why that happens is, this is what is called the euglycemia or normoglycemic DKA. And this is reported in patients who are treated with this SGLT2 inhibitors and or patients with severe sepsis and pregnancy. These are the two other categories of patients who can also exhibit this particular complication. And treatment is more or less same with regard to fluids, but insulin alone should be given in a very careful manner so that we don't drift to hypoglycemia because the blood sugar levels are low. Now, this is the SGLT2 induced euglycemic diabetic ketoacidosis. The precipitating factors for these patients are acute illness, dietary changes, underlying malignancy or cocaine use or pregnancy. Symptoms are more or less same: asthenia, tiredness, excessive urination, abdominal pain, vomiting, change in mental status, all common to DKA. But the diagnostic criteria is moderate hypoglycemia, less than 300. There is metabolic acidosis with a high anion gap, and ketonemia also is present. Now, what is the mechanism for that in these patients who have euglycemic is, there are two things. One is these drugs, the SGLT2 drugs act on the kidney in the proximal tubule, and they don't allow the reabsorption of glucose that is filtered. So there is glycosuria, and sodium also is lost. Natriuresis also is happening. And there is an increased reabsorption of ketone bodies. So this will help to increase the plasma ketone levels. And secondly, what happens, because there is a reduction in the blood glucose by not allowing reabsorption of glucose, insulin secretion starts reducing and glucagon production increases to restore the blood glucose level. This will result in lipolysis, free fatty acid, and the same beta oxidation process which happens in excessive glucose also happens, and that also results in ketogenesis. So there are two sources for ketones in this SGLT2. One is reabsorption of ketone bodies, and second is generation or ketogenesis by beta oxidation, both resulting in increased plasma ketones in patients who are being treated with this particular drug. And these are the various insulin preparations that we have. They are called aspartate, glulisin, lispro, and regular, which are all called short acting. Then there is a long acting, etimer and glargine. These are all drugs which are given for on a daily basis dosage, once a day dosage. Now, what is the common question they ask you in the examination is, what is the peak action? When is the peak action of ditabir and glargine? There a peak action? You can see in the slide there is no peak action because they are given mainly to maintain the bolus secretion of insulin. Okay, so they produce a normal level throughout the day. So there is no peaking like other insulins. That is the advantage. So they say you can continue with glargine or determine because it is unlikely to produce a hypoglycemia because only slow release is there. How do you achieve this quicker action and long action? What is the molecular nature of the insulin which makes it as a short acting, intermediate acting, or a long acting? What is the molecular nature of a normal insulin? How is it able to produce its action? Any idea? So the normal insulin is a monomer. It is a single compound. Whereas whenever it is in the stored form, it has to become a polymer, hexamer or a dexamer. So that it is 6 molecules of insulin combined together, then it is called a hexamer. Okay? So this hexamer has to break down into a single molecule and become a monomer, then only it will become active. So if you want any insulin to act for a long time, you make it into a polymer with many molecules united together. So they have to be slowly cleaved and then made into a monomer to produce the desired action. Okay? Whereas this aspart, glulisin, and lispro, they are all called insulin analogs. They are more or less like the normal insulin produced in the body in a monomer form. That is why they are able to have a very quick onset of action of 10 to 15 minutes. So this question they may ask you what determines the speed of onset of action. So for faster action, the insulin should be a monomer. For slower action, it can be a polymer in the form of a hexamer or a decamer or even a pentamer. All these things are available. So that is how they make it a longer acting drug. And nowadays the combination, earlier it was NPH insulin and regular insulin combinations were used. Nowadays you can see there is a combination of this insulin analogs like lispro, aspart along with the protamine insulin so that you can have a basal production as well as immediate bolus available in a very short acting form, in a quicker acting form. So the earlier combination of NPH with regular is now changed to protamine with lispro or protamine with aspart for a combination of all these things. So the earlier one 70-30 mixed start is used to be NPH 70% and 30% regular. That is the combination that has been used for a long time. These new preparations are available. Any other newer mode of insulin is available latest other than this parenteral where you have to stick it or inject in your body? What is that?
Afreza,
Eh? Nasal
Exubera and
sprays
Afreza.
are being tried now. Okay, Afreza. It's called Afreza, which is a nasal spray. And sometimes the examiners may ask you about the correlation between HbA1c and the blood sugar level. So normally we say less than 6 is supposed to be normal. 5.5 to 6 is normal. From 6 onwards, you say impaired glucose level, then regular diabetic 7, 8, 9, and 12. So if the HbA1c is 6, the average blood sugar is about 126. And if it is 7, it is 154. If it is 8, 183. If it is 9, 212. So if it is HbA1c 12 means 298 is the average glucose. So this relationship also is sometimes asked, which you have to remember. So to convert HbA1c to estimated average glucose, the formula is 28.7 multiplied by the HbA1c minus 46.7. So 0.7 is common to both. So 28 and 46 you have to remember. So multiply the HbA1c with 28.7, subtract 46.7 from that, you will get the estimated average glucose. Of course, tests for autonomic nervous system, all this we have discussed in the earlier class, so I'll just skip through that. Sliding scale regime for various regimes that are required for control of blood sugar also will be asked in the examination. So this is the oldest and method still followed by many physicians. So if the blood sugar is 150 to 200, you give regular, that is short-acting insulin 2 units, 250 to 21 to 250, 4, 6 like that. It keep on increasing. Whereas the regimen has got very little. This is subcutaneous. You can they use the same thing as a IV infusion also, as a regular IV infusion. And the other method is modified Albury regime. There is a Velour regime. The main idea for Velour regime is to avoid the need for expensive infusion pumps and other things. And they say less than 70, no insulin, start 100 ml of 5% dextrose, and then review every 15 minutes. If the blood sugar in the morning before surgery, for this is mainly for elective procedures, 71 to 100, stop insulin, infuse dextrose 100 ml per hour. 101 to 150, 1 unit of insulin added to 100 ml of 5% dextrose. 150 to 200, you increase the insulin to 2, like that, 3, 4, everything. Now, how do you administer that? You will see you require only a pediatric Burette system IV infusion set. So you fill 100 ml of dextrose in that, and depending upon the blood sugar, you add through the side port 1 unit or 2 units or 3 units, depending on that, and then infuse it. The idea why this is prescribed by CMC Velour, mainly to avoid the expensive use of the infusion pumps, number one. Number two, in the other Albert E. Thomas regime and other things, you have to discard the entire solution which you prepared. If the blood sugar changes, then you have to make a fresh one. So that the expense also is avoided by using this method. So this is now only available in some of the textbooks, but this was mainly a journal presentation. But now gradually all the textbooks are including this also as part of the methods of controlling blood sugar, both intra and post-operatively. Now coming to the topic of discussion today, patients undergoing vascular surgery frequently have multiple comorbid conditions that should be optimized prior to surgery. That is the first and foremost thing. The cardiovascular system, myocardial infarction, arrhythmia, heart failure. This is the most important point you have to keep in mind. So thoroughly evaluate the cardiovascular system, and then for that you have to do a cardiac stress testing if you suspect anything, echocardiography, and blood pressure to be measured in both the arms to determine whether there is a difference, because even the upper limb vessels may be affected. And need for coronary revascularization is very, very important to assess. And then beta blocker therapy should be maintained in patients who are chronically on that. So improper timing and dose titration may increase the risk of stroke and mortality. And patients may be on antiplatelet. Aspirin can be continued without any problem if the patient has a coronary stent. Whereas the other antiplatelets we have to think of and then titrate it with, or replace it with heparin. Statin should be continued post-operatively and ideally started 1 week to 30 days before the procedure. Warfarin may be, some patients may be taking for atrial fibrillation, but has to be stopped 3 to 5 days prior to surgery, and we can substitute it with heparin. And if your regional technique is planned, you have to decide what is the antiplatelet and then withhold it and then switch over to other titrable parenteral anticoagulant and plan B. Follow the NICERA guidelines or the other guidelines that are available for regional technique. And respiratory system, many patients may have high tobacco use and may have compromised pulmonary function, as in our case. And renal system, pre-existing renal dysfunction is very common, and due to decreased number of functioning granuli, they have very little capacity for autoregulation. So the autoregulatory power is lost, and any hypotension will result in acute kidney injury. And also the ischemia reperfusion or atheroembolism or nephrotoxic contrast dyes, which are used sometimes for identification of the block, all that can result in renal damage. So patients who have a chronically elevated serum creatinine level may have a greater morbidity and mortality following vascular surgery. And patients who are evaluated with a contrast may develop a contrast-induced nephropathy. This is one of the short note questions, so I thought I will include a little bit detail about that. So CNS diagnosed by an increase in serum creatinine beginning 24 to 48 hours following contrast exposure. So in a patient with no other reason for acute kidney injury. So there should not be any previous problem. And risk factors for contrast-induced nephropathy include chronic kidney disease, diabetes, anemia, heart failure, use of high osmolar contrast, and high volumes of contrast also. Pre-treatment with N-acetylcysteine may be considered at a dose of 1200 milligram orally every 12 hours on the day before and on the day of contrast may help in reducing this. Coming to CNS patients may have carotid bruise and should be questioned for any PIA attacks or earlier cerebrovascular accidents. And endocrine, majority of them have accelerated atherosclerosis, long-standing diabetes, and autonomic dysfunction, silent MI, and nephropathy. So all these things have to be evaluated. And hematological system, they may have heparin-induced thrombocytopenia, especially if they are on long-term heparin preoperatively. We have to make sure that they don't suffer from heparin-induced thrombocytopenia. That is, and again, some sort of antigen antibody reaction type. Formation of antibodies between heparin and platelet factor 4 complex results in the platelet not functioning properly, and patients who are on heparin go for reduced platelet function. If elevated, the serum serotonin release assay is the one test which will indicate whether the patient is having a heat syndrome. And if SRA is negative, heparin can be used intraoperatively, irrespective of the result of anti-PF4 antibody test. If both anti-PF4 antibody and SRA are positive, then you should stop the heparin and go for alternate drugs like the non-heparin lepridine or argatroban or factor 10A inhibitor like danapiride sodium or fondaparinux. And you must avoid platelet transfusions also. And lower extremity bypass grafting can be done. Nowadays, most of them are done endoscopically by putting a stent. But if it is not over the distal runoff, then open surgery will be a better than endovascular procedure. And the venous grafts were used earlier, but nowadays we are using mostly synthetic grafts are being used by the surgeons. Blood loss during the first time surgery will be usually minimal, but revision procedures may cause a more excess bleeding. Routine monitoring is usually sufficient, but patient comorbidities will decide whether you require invasive monitors or not. And there is no significant difference in mortality or morbidity between regional and general anesthesia for lower limb revascularization. Coming to general anesthesia, any technique is appropriate provided hemodynamic stability is maintained. And regional anesthesia, potential advantages are with the sympathetic blockade, you get a good vasodilation, improved pain control, and easy instrumentation, avoiding airway infiltration, improved ability to detect symptoms of MI or hypoglycemia in a patient who is awake. However, long procedures under regional anesthesia can pose a challenge for patients who may become restless. Normally, a continuous lumbar epidural catheter is used, and for iliofemoral bypass, a spinal or epidural will require a higher level, up to T10, because of proximal extension and peritoneal retraction. And neuroaxial anesthesia is contraindicated in anticoagulated patients. Clotting abnormalities must be corrected with either FFP or vitamin K or protamine. before catheter incision, and patient must receive also a general anesthetic. There is no evidence that the subcutaneous administration of unfractioned heparin for DVT prophylaxis increases the risk of epidural hematoma. So patients who are on subcutaneous unfractioned heparin need not you need not avoid epidural placement. If postoperative warfarin therapy is needed, epidural catheter should be removed before the onset of anticoagulant, that is within 24 hours of first dose of administration. So this is how the iliofemoral bypass. You can see this is the inguinal ligament. So the graft is placed in the bifurcation at the earliest. This is the block that is there. So graft is placed prior to the block and then connected to the femoral. So it has to come through under the inguinal ligament and then the anastomosis. So two-end anastomosis and the creation of the space between this is very important. And sometimes the other options are you can do this is the iliofemoral, you can do femorophemoral, you can do femoropopliteal, or you can transfer from the opposite drawing also, femorophemoral form of crossover bypass. So these are all some of the options that are there for this presentation. This is what I thought I will share with you.